infection in neonates, it can be divided into two parts. One is superficial infections, whatever the examples I gave now, and other is the deep-seated infections, which is termed as neonatal sepsis. Fine. So something like cold infection or any local infection of the wound or any oral thrush after giving some long-term antibiotics or conjunctivitis, all these things comprise superficial infections. They cannot be called as neonatal sepsis because there won't be underlying septicemia or bacteremia that is present. Okay. And so coming to neonatal sepsis as such, any septicemia or pneumonia, any deep-seated infection for that matter, or osteomyelitis or meningitis or UTI, septic arthritis. So any of these deep-seated infections will be called as neonatal sepsis. Okay, any of the systemic infection or deep-seated infection is called neonatal sepsis. Now, so we saw infection in newborns. Among them, it is superficial infection and deep-seated infections, and these deep-seated systemic infections are called as neonatal sepsis. Now, coming to the proper definition, neonatal sepsis is a clinical syndrome characterized by signs and symptoms of infection. What are these signs and symptoms? We'll learn it. Fine, we'll learn it. See, eventually we'll learn it. Signs and symptoms of infection with or without accompanying bacteremia. Why without? Because not all the times blood culture can come positive, correct? Either we would have already pre-treated with antibiotics or we have withdrawn blood culture properly, but still most of the times blood culture still can end up being negative, correct? So without accompanying bacteremia in the first 28 days of life. Fine, that is the definition. Clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first 28 days of life. Now, what is the etiology? What are the organisms that can cause bacteremia or neonatal sepsis? So this comprises again gram-negative or gram-positive organisms. Gram-negative, most common is Acinetobacter baumannii, followed by Klebsiella, E. coli, etc. And gram-positive, Coagulus negative Staphylococci, Staph aureus, Enterococcus, etc. These are the few organisms that can cause neonatal sepsis. Now, coming to the classification of neonatal sepsis, how do we classify this? This classification is mainly based on the source of infection, like what is the source of infection that is responsible for neonatal sepsis. Now, so we divide it into early onset sepsis and late onset sepsis. Early onset sepsis are the ones who present before 72 hours of life, and late onset sepsis are the ones who present after 72 hours of life. Now, why is this difference? Because the source of infection becomes different. The source of infection in case of early onset sepsis is usually the maternal genital tract itself, okay, maternal genital tract itself or the delivery area, okay, or from the hands of the delivery personnel. So that is early onset sepsis, and this early onset sepsis usually presents as pneumonia, okay. So early onset sepsis is the one that comes within 72 hours of life. It is called so because the source of infection is either the genital tract of the mother or the delivery area or the infected hands of the delivery personnel. Fine, and it presents as pneumonia usually. Late onset sepsis is the one that presents after 72 hours of life. Now, what is the difference over here? Over here, it is usually hospital-acquired infection. Like neonate has birth asphyxia, we have shifted it to NICU, and in the NICU, the way we handle the babies, we might not have followed thorough aseptic manuals. Like you will be putting UVC, that could have caused, we'll be putting IV cannula, that could have been the source of infection. Or our hands itself, we might not have washed our hands properly or sanitized our hands properly, that will be the cause. Fine. So there are numerous sources of infection. So it is usually hospital-acquired infection or a well baby coming at 4th or 5th day of life with respiratory distress, and on X-ray you'll find a patch, correct? So that can be community-acquired pneumonia, fine. Or then 4th or 7th or 8th day of life coming with convulsions, that can be meningitis, that is community-acquired, fine. So this usually presents as septicemia, pneumonia, or meningitis, and source is hospital-acquired infection or community-acquired infection. So this is how we classify neonatal sepsis, early onset and late onset, based on the source of infection. Now, for early onset sepsis, what are the risk factors? This we already know. It is either to do with maternal genital tract or the delivery area. So rupture of membranes for more than 24 hours because there will be breach, correct? Once the membranes are ruptured, the vaginal tract is directly connected to the baby. So whatever the organisms are there that can go invade, enter into the baby's circulation and cause infection, or spontaneous preterm labor, or there is rupture of membranes and the amniotic fluid gets infected. So chorioamnionitis, or prolonged labor, or unclaimed PV examinations, and perinatal asphyxia. These are few of the risk factors, and few of the extreme risk factors is rupture of membranes for more than 72 hours, or chorioamnionitis, or foul smelling liquor. In this case, we'll have to take it as probable sepsis, and we might have to start the baby as well on antibiotics because we are suspecting sepsis in these children. They're extreme risk factors. Fine. And now, what are the risk factors for late onset sepsis? The newborn baby itself can be susceptible, like any low birth weight babies or IUGR babies, or admission to NICU, lack of breastfeeding, poor cord care, unhygienic cord practices, and any of these superficial infections, if not treated properly, that itself can lead to bacteremia and sepsis. Aspiration of feeds, okay, administration of parenteral fluids, because we'll be administering IV fluid cannula, that itself can cause infection, and those cannula will be handled multiple number of times, that can be source of infection. Any of the invasive procedures, mechanical ventilation, which can cause ventilator associated pneumonia, correct? So all these things are risk factors for late onset sepsis. Next, we saw in definition that signs and symptoms of septicemia. So what are these signs and symptoms? Coming to the clinical features of neonatal sepsis. Clinical features will be, it can either be non-specific features or specific belonging to certain systems. Non-specific features can be hypo or hyperthermia, okay, and it can be lethargy, poor cry, refusal to suck, okay. These are all constitutional symptoms which you can expect. Poor perfusion and prolonged CFT because of shock. The child baby can be hypotonic. Bradycardia or tachycardia can be there either because of myocardial depression or the endotoxins causing myocardial depression, or it can cause myocarditis and can cause tachycardia, or baby might end up in shock and that can cause tachycardia. Fine. Respiratory distress or apnea. Respiratory distress can be because of pneumonia, and then there can be CNS suppression that can cause apnea, okay. Hyperglycemia or hypoglycemia is possible, and metabolic acidosis. Fine. Now, what are the specific features coming to each specific symptoms system? CNS, there can be irritability. Meningitis can cause irritability, seizures, high pitched cry, okay, arching of the back, all these things because of meningeal irritation. Cardiac, there can be cardiac, the endotoxins can lead to depression, can cause myocardial depression, that can lead to hypotension, poor perfusion, shock, etc. Fine. GIT, there can be feed intolerance, okay, vomiting can be there, diarrhea can be there, abdominal distension can be there, paralytic ileus can occur, okay, septic ileus can occur. Then hepatic, there can be conjugated hyperbilirubinemia is possible, or coagulation abnormalities are possible. INR can get deranged, okay, that will lead to bleeding manifestations again. Fine. Renal, AKI can take place, and skin, the baby will become scleromatous, thick cardboard like scleromatous. Fine. These are the clinical features of neonatal sepsis, non-specific and specific clinical features. Next, coming to investigations. How do we investigate the baby? That is where we call it as sepsis screen, which consists of total of 5 investigations, and any 2 of the above sepsis screen, any 2 of the 5 investigations comes out to be positive, then we can term it to be positive sepsis screen. Fine. So what are the 5 investigations that should be done? Total leukocyte count less than 5,000. Fine. Absolute neutrophil count less than 1,800. Micro ESR more than 15, CRP of more than 10, and immature to total neutrophil count of more than 0.2. These are the 5 investigations. Next is gold standard. What is gold standard? Gold standard is to get the organism itself and to know the culture and sensitivity of the pattern of the organism, so we can narrow down the antibiotic and target whichever antibiotic the organism is susceptible to. Fine. So blood culture is the gold standard for diagnosis of sepsis. Next, what are the other investigations? Other inflammatory markers like procalcitonin can be sent. Then chest X-ray can be done. If suspecting meningitis or late onset sepsis, we'll have to do CSF study. And a child coming at day 23 of life, you find conjugated hyperbilirubinemia, then you will have to suspect blood culture positive sepsis or urosepsis. So urine culture and sensitivity can be sent. Okay, certain molecular assays like PCR can be done to know which organism as such, but these are higher end of investigations which we usually don't doing. And certain newer biomarkers are coming up which is still not used clinically but might be asked in your MCQ. So I have mentioned like serum amyloid A, hepcidin, CD64, CD11B, and ICAM. Fine. Now next is the treatment. So we'll have to give supportive treatment. So because once there is sepsis, as we have seen, there can be poor perfusion, CFT can be prolonged, there can be apnea. So all these things we'll have to manage it supportively other than treating the baby with specific antibiotic, right? So we'll have to hypo or hyperthermia as possible. So temperature has to be controlled. Since that baby can go into apnea or can have respiratory distress secondary to pneumonia, airway and breathing has to be controlled. Since the baby can go into shock, circulation should be managed and shock should be managed, correct? So that includes the supportive care. Next is specific care. How do we treat the infection as such? How do we target the organism as such? And that is purely based on antimicrobial treatment. And the antimicrobial policy varies from hospital to hospital. It is based on the culture and sensitivity of pattern of the particular NICU, correct? So that totally varies and depends on the particular hospital policy. If meningitis, we usually give for 21 days. Blood culture positive, we give for 14 days. And we are still suspecting sepsis, but culture is negative. In that case, we give for 5 to 7 days. So any doubts? Any doubts in neonatal sepsis? Or on YouTube, any doubts? Fine. So let's move on. Next topic is respiratory distress. Fine. Now, respiratory distress is a very broad category, okay, because there are numerous diseases that can cause respiratory distress in newborn. Fine. So, for us to know what are the causes, first we'll have to know what is respiratory distress as such. Okay. So, definition of respiratory distress is presence of any two of the following symptoms. So, what are these two? Either respiratory rate of more than 60 cycles per minute. So there is tachypnea, okay. Subcostal or intercostal retractions, that means there is a distress present, and grunting. So of the three, if any two of the following is present, then we can term that newborn baby has respiratory distress. Fine. Now, what can cause this respiratory distress? What can cause this respiratory distress? Then we can categorize it. One is any abnormality in the airway. If there is any obstruction to breathe, like baby might have bilateral choanal atresia, or my baby might have micrognathia or retrognathia because of Peary-Robin sequence, or there can be tracheoesophageal fistula, and there will be so much frothing of secretions that secretions ends up in the lungs, might cause airway blockade and cause respiratory distress. And laryngomalacia can be there, vocal cord paralysis can be there. So any abnormality in the airway as such can cause respiratory distress. Next, what comes below airway? That is the lungs. So any pathology in the lungs can cause respiratory distress. That includes RDS, transient tachypnea of newborn, mask, congenital pneumonia, any air leak syndrome like pneumothorax. Okay, so various reasons can cause various diseases can cause pulmonary diseases can cause respiratory distress. Now, what is next to the lungs? That is obviously the heart, correct? So, what are the cardiac manifestations or cardiac diseases causing respiratory distress? So, any congestive cardiac failure, cardiomyopathy, congenital heart disease, arrhythmias can cause again respiratory distress. Then if there is any bony abnormality, that as well can cause. And finally, the neuromuscular diseases can cause many neuromuscular disorders like myasthenia gravis or any maternal medications that has led to sedation of the child, or any birth trauma, asphyxia, meningitis as such can cause abnormal pattern of breathing and respiratory distress. Fine. Next, other causes like sepsis, anemia, polycythemia, hypo or hypothermia as well can cause respiratory distress. So these are the causes of respiratory distress. Next, how do we assess the baby with respiratory distress? And this all of us know there are two scoring systems. One is Silverman-Anderson scoring and other one is Downey scoring. This is usually used in a preterm child and this is usually used in a term child. Fine. So Silverman-Anderson scoring and Downey's scoring. These are the two scoring systems available to assess the baby and know the severity. And what are the components? This can be remembered by simple mnemonic. For Silverman-Anderson scoring, it is called as X lung. X lung. So it includes external retraction, okay, lower chest retractions. Lower chest retractions is nothing but the retraction below the mid-axillary line. Below the, after drawing this mid-axillary line, whatever retractions is over here, that is called as lower chest retractions. Whatever is above, it is called as upper chest retraction. Next is nasal flaring, and finally G for grunting. Okay, based on this is these parameters we grade respiratory distress by SAS score or Silverman-Anderson score. Next is Downey score, which is usually used for term babies, and the mnemonic goes as CIGAR, CGARR, and this includes cyanosis, grunting, air entry, retractions, and respiratory rate. Okay, these are the parameters, and this is the simple mnemonic through which you can remember. Based on this, we can grade it as mild, moderate, and severe. Mild is between 0 to 4, moderate is between 5 to 7, and severe is more than severe. Why do we grade? Based on this, we usually decide how severe it is, and two, what is the intervention needed. Like for mild, this can be managed with nasal prongs itself. If it is moderate, we go for higher mode of respiratory support like CPAP. If it is severe, we go for even more higher mode like mechanical ventilation of the baby. Fine. So that is the importance of assessing the child, grading the severity, and how to know what treatment is to be given. Next is we'll come to the more important diseases, which includes Meconium aspiration syndrome, transient tachypnea of newborn, and respiratory distress syndrome. These are few of the important diseases which we'll have to know and which will invariably be asked in your exams. Respiratory distress syndrome is even called as hyaline membrane disease. All of us know RDS or respiratory distress syndrome, also called as hyaline membrane disease. Now, what is it caused? What is it caused? It is caused because of insufficient pulmonary surfactant in the alveoli. Okay, if the surfactant is not produced in enough amount, either there are certain external factors hindering the secretion, or baby is born too preterm, it is born very early, and the surfactant is not produced in enough number to support the lung. So insufficient pulmonary surfactant in the alveoli. What is the pathogenesis? The surfactant, which is usually secreted by the type 2 alveolar cells, this helps in reducing the surface tension. So surfactant which is present, that reduces the surface tension, and this doesn't allow the alveoli to collapse. It doesn't allow the alveoli to collapse this way, correct? That is the role of the surfactant. So in its absence, what happens? In its absence, what happens is there is increased surface tension. Once there is increased surface tension, the alveoli tends to collapse, as we see over here, correct? There is no surfactant, there is increased surface tension, so alveoli ends up collapsing, correct? So alveoli collapses during expiration. And once inspiration, the alveoli might expand because there is air entering, but expiration, once the air exits, it ends up collapsing. Okay. So once this happens, there is more amount of effort needed to open up a collapsed lung as compared to a lung that the alveoli that is already open, correct? So more effort is needed. So baby puts in more work of breathing, which will result in respiratory distress. And since not enough amount of air is entering the lungs, there will be hypoxemia on the other side. So one side there will be hypoxemia, on the other side there will be increased work of breathing causing respiratory distress. So that will result in inadequate oxygenation and increased work of breathing, which will result in hypoxemia and acidosis. Okay, this hypoxemia itself will lead to respiratory acidosis, like later on leading to metabolic acidosis, correct? Because in the cells, there is the metabolism is not taking place because of inadequate oxygen. What will this lead to? This will lead to pulmonary vasoconstriction, right to left shunting. If this happens, there is hypoxia, pulmonary vasoconstriction, right to left shunting, there will be more hypoxia, correct? This more hypoxia will lead to respiratory failure. And on the other hand, there will be ischemic damage to the alveoli because there is hypoxemia, which will lead to ischemic damage. Once this happens, there will be transudation of proteins, there will be all the infiltration of cells taking place, which leads to formation of a membrane, correct? This leads to formation of membrane, which is called as hyaline membrane. And so the disease is named as hyaline membrane disease. Next, coming to the risk factors. What all can cause this respiratory distress syndrome? One is child being born preterm. Mostly less than 34 weeks, it is common because by 36 weeks, there is sufficient surfactant for baby to maintain normal respiration. 34 to 36 weeks, baby can still pull through, but less than 34 weeks, it is quite common. Maternal diabetes, because of increased fetal insulin, inhibits surfactant production. Then any asphyxia or acidosis as such can inhibit surfactant production, and cesarean section is one of the risk factors for reduced surfactant synthesis because there won't be enough stress. Stress itself is one of the stimulus. The baby coming through the vaginal tract can cause sufficient amount of stress, and that stress itself will produce surfactant. That is not happening in case of cesarean section. So that is one of the risk factors. Now, how do we assess? How do we predict that the baby, like we have a preterm baby, in that, how do we know whether there is enough surfactant? Okay, that is forms part of antenatal assessment, correct? So we can know the lecithin levels, or we can know the lecithin to sphingomyelin levels, and ratio of more than 2 predicts that there is lower risk for development of respiratory distress, except in few cases of maternal diabetes, erythroblastosis fetalis, and intrapartum asphyxia. Next, phosphatidylglycerol can be used because in this, even if in the presence of maternal diabetes, the prediction is good. Okay, or on histopathology, demonstration of lamellar bodies, amniotic fluid lamellar bodies. These are few of the antenatally how we can assess the risk that baby might have respiratory distress syndrome. Now, how do we diagnose it? Diagnosis is clinical diagnosis is by defining respiratory distress itself, that is tachypnea, retraction, or grunting. So these clinical features. Okay. Next is by X-ray. On X-ray, what are the findings? On X-ray, what are the findings? As we see over here, the first X-ray, fine granular appearance can be there, or as we can see over here in the second X-ray, ground glass appearance can be there, or the fourth X-ray, left lung, if you concentrate on, whiteout lung will be there, and whatever finding is there, it is usually bilateral and symmetrical, and you can have ear bronchograms as well. See over here, there is ear bronchogram, one ear bronchogram, or over here there is one more ear bronchogram. See, all these things are ear bronchograms. So ear bronchograms extending peripherally. So these are few of the X-ray findings of RDS. And what are the stages? How do we, based on X-ray, what are the stages? Stage 1 is reticulonodular granular pattern. Stage 2 is ear bronchograms. Stage 3 is decreased transparency plus blurring of the diaphragm and the heart. And stage 4 is whiteout lung. So this was the X-ray findings. Next is how do we manage? So we have already learned, after classifying the severity of respiratory distress, we give respiratory support. So if there's mild or moderate respiratory distress, it is given by CPAP. If there is severe respiratory distress, by mechanical ventilation. Next, as such, the pathology is decreased surfactant, correct? So now what do? We give surfactant to the lungs. So neonates with moderate to severe So neonates with mild or moderate to severe respiratory distress, we give surfactant. And what is the technique that is used to give surfactant? It is called as insure technique. Okay, we intubate the child, we give surfactant, and we extubate. That is called as insure technique. In less than 28 weeks, it is better to give it in the labor room itself. So we give it because it saves time. So we give prophylactically. We give, if not, we can observe in the initial 2 hours and then give, which is called as early rescue, which is given within 2 hours of birth. Okay, and late rescue is the one which is given after 2 hours of birth. Early rescue is better because it is associated with better outcome, and few of the side effects can be airway obstruction, because the surfactant which you have administered itself can cause plug, which will lead to airway obstruction. And if there is airway obstruction, there can be emphysematous changes in the lungs. If this emphysematous alveoli ruptures, that can cause air leak syndrome. Okay, and pulmonary hemorrhage is possible. Now, is it possible to prevent this from occurring? Is it possible to prevent respiratory distress? Yes. So in preterms, we can, any baby with less than 34 to 35 weeks period of gestation, we'll have to give antenatal steroids, because this increases the surfactant production. In India, we usually give dexamethasone 6 mg every 12th hourly, 4 doses. Okay, betamethasone 12 mg every 24 hourly can as well be given. And what are the benefits? Any other benefits other than RDS? Yes, it helps in reducing IVH in preterm babies. It helps in the reduction of rate of necrotizing enterocolitis. Overall mortality is reduced, and there are incidents of PDA, reduction in systemic infections, decreased need of respiratory support, okay, and reduces the length of hospital stay. These are the various other benefits. Fine. So this was to do with respiratory distress syndrome. Any doubts till now? Any doubts till now? On YouTube, any doubts? Fine. Then we can continue with our next topic, that is, what is the next important cause for respiratory distress in newborn? That is meconium aspiration syndrome. Okay. Now, see, meconium staining of the amniotic fluid is different from meconium aspiration syndrome, correct? The staining of amniotic fluid can be present in number of babies, but that staining leading to disease is different. If that leads to disease and presentation of newborn with respiratory distress, then it is called meconium aspiration syndrome. Okay, so the incidence of MACF as such is high. It is around 10 to 15% of deliveries. Okay, so any type of stress like asphyxia, prolonged labor, IUGR baby, all these things can have meconium staining of amniotic fluid. Or a post-term baby. So all these things will become stimuli to the baby, and this stress will lead to baby passing stools in utero. So there will be meconium staining of amniotic fluid. But among this, only 5% of them develop meconium aspiration syndrome. And even in that 5%, very few of them, around 30 to 50%, might require any sort of respiratory support. Okay. So this is to do with the incidence. Now, what is the pathophysiology? So what happens is either there can be physiological passage of meconium in post dates, or like the number of various reasons I've listed out, any sort of stress to the newborn, like fetal hypoxia or cord compression or an IUGR baby or prolonged labor. So all these things will lead to meconium passage. And what does this do? This will lead to meconium staining of the amniotic fluid, and this thing goes into the lungs, correct? So amniotic fluid goes into the lungs of the baby in utero. So what happens is either if there is postpartum aspiration of the meconium or in utero gasping of this MSCF, this leads to meconium aspiration. Okay, this aspirated meconium can because there will be meconium plugs, right? This meconium plugs, what it does is it will go and obstruct the airway. If there is proximal peripheral airway obstruction, okay, this goes into the peripheries. There is the alveoli. Here it goes and obstructs. What will happen? Alveoli will collapse. Once alveoli collapses, there is atelectasis. So there will be few alveoli that is collapsed, few alveoli that are opened up. Then what will happen? This will lead to ventilation perfusion mismatch. So this is one of the pathology. Next, what will happen? It will partially occlude the airway. When there is partial occlusion, what happens is there will be trapping. The inspiration, air goes into the alveoli. Inspiration, if there is partial occlusion, inspiration, air goes, but expiration doesn't take place. This is what we call as ball valve mechanism. So once this happens, what happens? The alveoli bulges, correct? So there will be emphysematous change in the alveoli. If there is too much of this, it break opens. So this will lead to air leak syndrome. This can lead to air trapping and air leaks. Okay. And what as well can happen is this meconium will lead to inflammatory damage and chemical pneumonitis. So all these things put together can lead to acidosis, hypoxemia, and hypercapnia. Once this happens, there will be remodeling of the pulmonary vasculature, and that will lead to persistent pulmonary hypertension. So this is to do with the pathophysiology of meconium aspiration syndrome. Hope you guys understood. Now, how do we manage? It is more of symptomatic management or supportive management of the child. So one is at the time of birth, is there any difference in the resuscitation protocol? Previously, it used to be there, but now the routine protocol itself is followed. So if it is a vigorous baby, then routine newborn care can be given. If it is a non-vigorous baby, we don't have to. Previously, it was indicated to intubate the child and do intratracheal suctioning, but at present that is not followed. Okay. Next is, what do we do? Like it is a vigorous baby and routine newborn care is offered. Can that baby develop meconium aspiration syndrome? Yes, it is very much possible, because the meconium that has gone into the lungs can, for that whole process to take place, like this we already saw, no? For this whole process to take place, it needs some amount of time, correct? So the period of worsening can range between at the time of birth until 48 hours of life. So neonates need continuous observation. So we'll ask the baby to review at NICU periodically, or we ourselves should go to the postnatal ward and see. We'll have the routine newborn care is given, rooming in is done, baby has to be breastfed, but it has to be kept under observation for the initial 48 hours. Okay. Next is on doing X-ray. What are the findings? On doing X-ray, what are the findings? Bilateral, diffuse, heterogeneous, fluffy opacities you see, correct? In bilateral lungs, these fluffy opacities are seen. So bilateral, diffuse, heterogeneous, fluffy opacities. And what is it suggestive of? It is suggestive of areas of atelectasis and areas of emphysematous. As we already saw it in the pathogenesis. Okay. And because there will be again emphysematous change, because there will be airway blockade, it will lead to hyperinflated. Hyperinflation is suggested by more than 7 rib spaces, and diaphragmatic flattening, as we see over here. And as a complication, ear leak and pneumothorax as well can be found. Next is, how do we treat? Treatment is by supportive care. One is again temperature, airway, breathing, and circulation has to be done, has to be taken care of. Assisted ventilation is the strategy, either by depending on the severity. If it is mild or moderate, CPAP can be used. If it is severe, mechanical ventilation can be used. Based on this, we can create the severity as mild, moderate, and severe. Mild is requiring less than 40% FiO2 for less than 48 hours. Moderate is requiring more than 40% FiO2 for more than 48 hours, not associated with ear leak. And the same, if associated with ear leak or persistent pulmonary hypertension, it is called as severe. If there is PPHN, we'll have to treat PPHN as well. And since meconium itself, if there is whiteout lung, that whiteout lung will be because this meconium has gone, it has led to chemical pneumonitis that has destroyed up all the surfactant, which has led to whiteout lung. So in that case, surfactant administration can also help. Complications we have already seen: ear leak in terms of pneumothorax or pneumomediastinum, PPHN, and later on, because of prolonged ventilation, pulmonary sequelae like bronchopulmonary disease. All these things can be found. Okay. And now coming to the last topic, that is transient tachypnea of newborn under respiratory distress. Now, what is the definition of transient tachypnea of newborn? Now, this is till now we have dealt with serious diseases, but TTNB is usually a benign, self-limiting disease which usually occurs in the term and late preterm newborns due to delayed clearance of the lung fluid. Okay, delayed clearance. That we'll understand this by looking at the pathophysiology. Okay, now what happens? Fetal lungs is in secretory mode. It is filled with fluids. Correct. That is what is fetal lungs. But what happens once the babies come out? There is transition. Correct. It goes into absorptive mode because it gets filled with air, and whatever fluid is there has to be absorbed. It is absorptive mode. And this transition, if it is hindered, if this transition doesn't occur smoothly, it leads to TTNB or transient tachypnea of newborn. Okay, and this transition is supported by maternal or fetal hormones like glucocorticoids and catecholamines. Okay. So if there is any delay or if there is any disruption in the clearance of fetal fluid, it will lead to transient pulmonary edema, which is called as, that will lead to respiratory distress. And so it is called as transient tachypnea of newborn. Tachypnea because there will be respiratory distress. Transient is because it's a very benign and self-limiting disease. Incidence is less, around 0.3 to 0.6% in term babies and 1% in preterm deliveries. And what are certain risk factors? Cesarean section is one of the important risk factors. Others can be precipitous birth or preterm birth, male gender, family history of asthma, macrosomic babies, maternal diabetes, and multiple gestations. These are few of the risk factors. Now, coming to the clinical features, it is it presents with respiratory distress within first 6 hours of birth. Okay, respiratory distress within first 6 hours of birth, and it is usually mild to moderate respiratory distress. We will not get severe respiratory distress, which we found in Meconium aspiration syndrome or the RDS. Okay, diagnosis, it is usually diagnosis of occlusion, exclusion. If we rule out in all the other causes of respiratory distress, finally we can think of transient tachypnea of newborn. And what are the X-ray findings? X-ray findings include hyperinflation of the lungs, okay, interstitial edema, which is seen as this perihilar sun streaks, right? See, as you see over here. Perihilar streaks, which is also called as sun ray appearance, okay, and there can be prominent, see over here, prominent fissure of the right upper lobe and rarely cardiomegaly. So these are few of the X-ray findings. Treatment is this usually supportive, okay, supplementary oxygen, and it usually requires FiO2 of less than 40%. In severe cases, it might need CPAP. Okay, but this condition is benign and self-limiting, so it usually resolves by 12 to 24 hours, and maximum it might last up to 72 hours. Okay, fine. I think so. We'll end our session over here today because we have another session at 7 o'clock. So the rest of the diseases we'll cover up in the next topic and wind up with the neonatology topic.